Very warm good evening to one and all present here today for the awareness webinar on neonatal components for newborn babies. Today, I'm really honored to invite Dr. Sanjay sir and Dr. Bharat Verma sir for this webinar, and also thanking the medical college, Zydus Medical College, Dahod, for this cooperation and continuous support till now. Now I would like to invite Dr. Sanjay Kumar sir to give the inaugural address.
Hi, good evening to one and all present. This is Dr. Sanjay Kumar, and I take this opportunity to introduce Dr. Bharat Parmar, who is our professor and head department of pediatrics. Sir has done both his undergraduate and postgraduate from and after retiring from BJ Medical College, he joined our Zydus Medical College and is working with us as a professor and head department of pediatrics with a team of another 12 doctors. I must say he is a stalwart in his subject. Very soon we are also starting a regional center at our medical college under his leadership for the sickle cell. He has done a lot of work. And coming to the today's topic, the important topic, and which all of us or each one of us should know, in the neonatal components for the essential newborn care, very much the senior resident and also my nursing staff. I think the nursing staff from the medical college also will join the year. So, ladies and gentlemen, let me present to you Dr. Bharat Parmar sir. Sir, over to you, sir.
Okay. Thanks for your kind words for my introduction. I am very thankful to Med Piper Company give opportunity to highlights about these important subjects as the neonatal component, importance in essential newborn care. Next, important component of essential newborn care for an intact survival of the newborn. There is antenatal care, safe delivery, neonatal resuscitation, preventions of neonatal hypothermia, preventions of neonatal hypoglycemia, promotion of breastfeeding, preventions of infection, and recognition of high-risk baby referral and the management. Challenges and constraints for these important of neonatal component for essential newborn care. The health and the well-being of children are intimately linked with the health, nutrition, and status of their mothers. Health and the well-informed mother are likely to produce healthy and a normal weight baby, whereas the undernourished and a high-risk mother are likely to produce high-risk and the low birth weight baby. More than 1/3 of the women in our country are undernourished with the body weight, baby weight less than 40 kg, height is less than 145 centimeter, and hemoglobin less than 8 gram percentage, and they are prone to develop variety of infection, genital colonization, bacterial vaginitis with a high prevalence of pelvic inflammatory disease, unsatisfactory reproductive health. Around 1/2 of the women in our country are illiterate and they lack personal and financial independence. The situation is further complicated by early marriage, teenage, and frequent pregnancy. Antenatal care of a questionable quality is available to 75% of the pregnant women and less than 25% rural delivery conducted by skilled birth attendant. The provision of essential newborn care is the most urgent key health priority in our country, and saving of newborn in India is a national priority to achieve further reduction in infant mortality rate. There is a need for a greater focus on a preventive rather than curative strategy. Previous slide. The provision of essential newborn care is the most urgent key health priority in our country, and saving the newborn in India in a national priority to achieve further reduction in infant mortality rate. There is a need for a greater focus on a preventive rather than curative strategy, because large number of the neonatal deaths are potentially preventable disorders such as hypothermia, hypoglycemia, septicemia, and birth asphyxia. To reduce neonatal mortality, essential and basic newborn care service should be available at all healthcare level because they are highly cost effective. The component of essential newborn care service include good quality of antenatal care, at least 3 antenatal visits, safe delivery, and optimal care at birth, promotion of exclusive breastfeeding, and prevention and early treatment of hypothermia and bacterial infection. The level of newborn care. Based on a birth weight and the gestational age, 3-tier system of neonatal care is proposed for developing countries. Level 1 care, more than 80% of the newborn required minimal care, which can be provided by their mother under the supervision of basic healthcare professional. The neonate weighing more than 1800 gram or gestational maturity is 34 weeks or more belong to this category. The care can be provided at home, subcenter, and primary health care level. Basic care at birth, provision of warmth, maintenance of asepsis, and promotion of breastfeeding form the mainstay of level 1 care. The traditional birth attendant and community health worker must be trained in the art of essential perinatal care. The level 2 care, infant weighing between 1200 to 1800 gram and having gestational maturity 30 to 33 weeks need specialized neonatal care supervised by trained nurse and pediatrician. The teaching institution, district hospitals, and the nursing home should be equipped to provide intermediate neonatal care. Equipment of resuscitation, maintenance of thermoneutral environment, intravenous infusion, and gavage feeding, phototherapy, and exchange transfusion should be provided in level 2 care. Intermediate neonatal care is needed for approximately 10 to 15% of the newborn population and should be available at all hospitals catering 1000 to 1500 delivery per year. Level 3 care, the intensive neonatal care is required for the baby weighing less than 1200 gram or those born before 30 weeks of gestation. Apex Institute or regional perinatal center equipped with centralized oxygen and suction facility, servo control incubator, vital sign monitor, transcutaneous monitor, and ventilators and infusion pump, and so on, are best suited to provide intensive neonatal care. Approximately 3 to 5% of the newborn population qualify for this level 3 care. Antenatal care. Antenatal care is an important element to ensure maternal, fetal, and consequently neonatal well-being. The objective of antenatal care, there is antenatal care to protect, promote, and maintain maternal health. Second, to identify high-risk mother and plan approximately and teach the element of neonatal care that is breastfeeding, and sensitize her for family planning. Schedule of care. Ideally, each mother should be attend antenatal clinics once a month in first 7 months and twice a month in next 2 months and weekly thereafter, our minimum 4 visits essential during third, 6th and 9 months. The component of the antenatal care include during first visit registration and complete health history and obstetric history. Then investigation should be carried out during antenatal visits. There's hemoglobin, urine, blood group, VDRL, HIV and USG, abdomen. And during subsequent visit, physical re-evaluation for the check for the blood pressure and edema, and obstetrical evaluation for a fetal well-being, and the breast examination and counseling, and investigation like hemoglobin, urine, the abdomen in abnormal case, and the nutritional support and dietary counseling and supplementation of additional 400 calories to the pregnant mother. Iron and folic acid supplement, 60 milligram of iron, 500 milligram of folic acid at 4 months onwards. Then tetanus immunization, the 2 doses 1 month apart, last dose at least 1 month before delivery in a previously immunized case, and 1 dose is necessary at least 1 month of delivery. Identification of high-risk mother during antenatal period and arrange more skilled care for them while continuing to provide appropriate care for other low-risk mother. Fetal monitoring include clinical, radiological, physiological, and biochemical evaluation of a fetus in utero, and assessment of the gestational duration by the last menstrual period, uterine fundal height, fetal event appearance of heart sound at 16 to 20 weeks, and quickening at 18 to 20 weeks. USG assessment crown heel length up to 12 weeks, biparietal diameter up to 28 weeks, and femoral length beyond this age. Assessment of the fetal growth maternal weight 9 to 10 kg in pregnancy, serial abdominal girth 1 centimeter per week from 20 week onwards, serial increase in UFH, and USG assessment, multiple pregnancy, congenital anomaly, abnormal placental morphology, oligohydramnios, fetal head, and head-abdomen ratio. Assessment of the physiological maturity, there is a lung surface tension maturity, LS ratio more than 2, amniotic fluid optical density more than 0.15, renal maturity, AF creatinine more than 2 milligram per DL, and skin maturity, there is AF cytology more than 20% of orange staining cell. The detection of congenital anomaly, USG karyotyping amniotic fluid, biochemistry, specific enzyme assay in suspected inborn error of metabolism, maternal and amniotic fluid alpha fetoprotein. Assessment of the fetal distress, fetal heart monitoring, fetal activity record, fetal scalp blood sampling for a blood gas analysis for the assessment of the fetal distress. Second important component is a safe delivery. Basic delivery room care begins even before the birth. An important component of essential delivery room care as follows. Pre-delivery review of antenatal health record, although the need for neonatal resuscitation may arise unexpectedly, it is possible to identify many high-risk pregnancy by review of antenatal record and refer them to adequately equipped center. Pre-delivery preparation in a labor room to receive the baby and resuscitate if needed. These include all normal deliveries should be attended by trained medical and health attendant, and labor room temperature should be 28 to 30 degree to avoid sudden heat loss. At birth, warmers should be switched on at least 15 minutes before the expected delivery. A pre-born baby receptacle lined with clean linen should be available to receive the baby after delivery, along with enough supply of extra linen. Availability of essential resuscitation equipment and drugs should be ensured in a working condition. Universal safety precautions for infection control are necessary to protect not only the baby, but also the health staff. 5 clean to ensure minimal asepsis during delivery include clean hand with quality hand washing and use of glove, clean surface to receive the baby, and clean blade to cut the cord, and clean clamp and tie to tie the cord, and clean dry cord with a no local application. Intrapartum intervention. Oropharyngeal suction soon after delivery of the head, which was earlier advised in all newborn with a meconium stained amniotic fluid, it is no longer recommended now. Timely clamping of the cord. Normally the cord should be cut after at least 30 seconds by the sterile blade, leaving at least 2 to 3 centimeters of the umbilical stump and tiring properly to avoid deep ligature and bleeding early umbilical cord clamping. Less than 30 seconds is not recommended unless neonates is asphyxiated and need to be moved immediately for resuscitation. Early clamping of cord is recommended babies with RH isoimmunization and firstborn twin, and delayed clamping of the cord recommended in IUGR baby and anemic baby. Third important component, neonatal resuscitation. Although the most of the newborn do not require any resuscitation beyond the maintenance of temperature, suction of airway, and mild stimulation, adverse perinatal event, birth asphyxia may preclude smooth neonatal cardiopulmonary transition unless assisted. Primary goal of neonatal resuscitation is to establish adequate respiration and cardiac output in asphyxiated newborn at birth to prevent early neonatal morbidity and mortality, as well as late sequelae of hypoischemic damage. Basic principle of neonatal resuscitation include to measure, restore, and maintain the 4 cardinal body function, that is temperature, airway, breathing, and circulation, often referred as TABC of resuscitation. Resuscitation alert. In case of preterm and post-term delivery, malpresentation or breech transverse lie, obstructed and prolonged labor, signs of fetal distress, meconium stained liquor amnia, altered fetal heart sound, movement, and abnormal taste of fetal well-being, premature rupture of membrane, cord prolapse, cord around the neck, interventional delivery, there's a LSCS, forceps delivery, and low Apgar score less than 4. This is resuscitation alert for resuscitation. High-risk pregnancy. Also, neonatal resuscitation required in case of high-risk pregnancy when there is a maternal, there is a preconceptional factor, age is less than 16 or more than 40, or primi or a grand multipara, malnutrition, hemoglobin less than 8 gram percentage, weight less than 40 kg, and height less than 145 cm. There is a maternal malnutrition, anemia, chronic medical disease, diabetes, hypertension, cardiopulmonary and renal disease, RH negative blood group, and bad obstetric history, it required neonatal resuscitation. Other obstetric antenatal factor, there is a multiple pregnancy or abdominal trauma, acute medical and surgical illness, torch infection, STD, pregnancy-induced hypertension and preeclampsia, vaginal bleeding, placenta previa, and antepartum hemorrhage, polyhydramnios oligohydramnios, and fetal abnormal maturity and congenital malformation, it requires neonatal resuscitation. So TABC of neonatal resuscitation, first there is a temperature control, warm under radiant warmer, drying of the baby, removal of wet linen, airway patency by proper positioning, oropharyngeal suction, breathing by tactile stimulation, positive pressure breathing, and endotracheal intubation. Circulation by chest compression and medication. A cord blood sample must be collected for a grouping and cross-matching and screening for intrauterine infection. Receive the newborn. The prevention of sudden hypothermia at birth is the most important component of immediate newborn care. As soon as the cord is cut, the baby should be received in a pre-warm tray, transferred under the warmer, and wiped gently to clean and dry, and no extra effort should be made to remove vernix that protect against hypothermia. Wet linen after wiping the baby should be discarded and changed. The warm chain important for prevention of hypothermia in newborn. Warm chain is a set of interlinked procedure carried out at birth and later, which will minimize the likelihood of hypothermia in newborn. Baby must be kept warm at a place of birth, at home or hospital, and during the transport from home to hospital or within the hospital. Common situation where the cold stress can occur at birth, after giving bath, during changing the nappy and clothes, malfunctioning heat source or removing baby from heat source, and while transporting the sick baby to the hospital. Step to prevent heat loss in a labor room, keep the delivery room 25 degrees to 30 degrees centigrade. Newborn care corner temperature is maintained at 30 degrees centigrade and drying immediately. Dry with one towel, remove the wet towel and covered with another pre-warm towel and warm transportation. Step to prevent heat loss in a postnatal ward, promotion of breastfeeding, appropriate clothing, cover head and extremity, keep the mother and baby together, and keep the room warm and postpone bathing till next day. How to keep baby warm? Use dry warm towel to hold the baby at birth and remove the wet towel after cleaning. Adequate and appropriate clothing, skin to skin contact next to the mother rooming, radiant warmer in nursery, and keep the room temperature of baby care area more than 25 degrees centigrade. How to keep the room warm? Avoid using air conditioner during summer. Don't use ceiling fan, especially at high speed, and keep the window and door closed in a winter and warm the room by heater. Kangaroo mother care is important care for newborn. Kangaroo mother care is a special way of caring for a low birth weight baby. It improves their health and well-being by promoting effective thermal control, breastfeeding, and infection prevention and bonding. The two components of kangaroo mother care are skin-to-skin contact. Early, continuous, and a prolonged skin-to-skin between mother and her baby is a basic component of kangaroo mother care. The infant is placed on her mother's chest between the breast. And exclusive breastfeeding. The baby of kangaroo mother care breastfed exclusively, skin to skin contact, promote the lactation and thus facilitate exclusive breastfeeding. The prerequisite for kangaroo mother care: support the mother in hospital, at home, and post-discharge follow-up. The benefits of kangaroo mother care: effective thermal control, increased breastfeeding rate, early discharge, less morbidity as apnea and infection, less stress, and better infant bonding. Prevention of hypoglycemia, another important component for essential newborn care. Hypoglycemia is a commonest metabolic problem in newborn, defined as blood glucose value is less than 35 milligram per dl during first 3 hours, less than 40 milligram per dl between third and 24 hours, and less than 45 milligram per dl beyond the first day, with a clinical manifestation irrespective of gestation. Etiology: normal fetal glucose level are 2/3 of the maternal value, which drop further during the first 2 hours before rising again to normalize by 3 to 4 hours of age. The poor fetal reserve in preterm and low birth weight and delayed feeding are the most common cause of neonatal hypoglycemia. Clinical manifestation of hypoglycemia not necessarily correlate with the blood glucose level, and most of the case present on a second and third day with abnormal movement, jitteriness, tremor, and seizure, abnormal behavior, apathy, limpness, refusal of feeding and coma, automatic disturbance, recurrent apnea, tachycardia, sudden pallor and sweating, and diagnosis raised low glucose, preferably by standard method, dextrotrix through the adequate for screening are not reliable at a very low glucose level. Preventions of hypoglycemia include early breastfeeding, routine glucose monitoring at high-risk newborn at 3 hours, 24 hours, 48 hours, and 72 hours after birth, and prevention and treatment of precipitating factor, hypothermia, and sepsis. Risk factor for neonatal hypoglycemia. So risk of this hypoglycemia in the preterm baby, low birth weight baby, IUGR baby, large spot date baby, infant of diabetic mother, delayed or inadequate feeding, RH incompatibility, exchange transfusion, critical illness, polycythemia, sepsis, hypothermia, and inborn error of metabolism. These are the risk factors for neonatal hypoglycemia. So how will you manage this neonatal hypoglycemia? The management of hypoglycemia depends on the severity of hypoglycemia. Intravenous correction is recommended only in symptomatic baby. Asymptomatic hypoglycemia does not need IV correction and treated with adequate feeding and additional sugar fortified feed if necessary. However, the case with blood glucose less than 25 milligram per dl must be reassessed after 30 minutes of feeding and need maintenance IV dextrose therapy as below if persist more than 35 milligram percentage. Manifest hypoglycemia is treated with IV bolus 2 ml per kg, 10% dextrose. Subsequently, all symptomatic baby should receive maintenance of IV dextrose and 10% 2 to 12 milligram per kg per minute till glucose level approach 60 milligram per dl, followed by gradual tapering. Resistant hypoglycemia to glucose bolus is treated in order to preference with IV hydrocortisone 5 milligram per kg, IV or IM glucagon 300 milligram per kg, it rarely required, and IV or per orally diazoxide 25 milligram per kg 8 hourly. Glucagon is a more useful in high insulin hypoglycemia in case of infant of diabetic mother and hemolytic disease of newborn. Outcome of this neonatal hypoglycemia: untreated symptomatic hypoglycemia may be fatal, though timely intervention ensure dramatic recovery. Persistent hypoglycemia in newborn may leave neurodevelopmental problem in 30 to 70% case. Another important component is the promotion of breastfeeding is essential to help mother of a healthy newborn baby to establish breastfeeding as soon as possible after delivery. Exclusive breastfeeding should be given for at least first 6 months of life, and complementary food should be started after 6 months of life. Advantage of breastfeeding. Benefits to the baby. Complete food species specific for easily digested and well absorbed, protect against infection, respiratory and diarrhea, promote emotional bonding, and better brain growth. Benefit to the mother, help in involution of uterus, delay pregnancy, lower risk of breast and ovarian cancer, and decrease mother workload. And benefit to the family and society, it save the money, promote the family planning, decrease need for hospitalization, and contribute to child survival. Breastfeeding should be continued during diarrhea as well as other minor illness. It helps the baby to get optimal nutrition and recover from the illness faster. Good attachment and good position will ensure effective sucking and prevent sore nipple and the breast engorgement. Infant takes several slow deep suck followed by swallowing, then pauses mean effective sucking. Breastfeeding is considered adequate if baby passes urine 6 to 8 times in 24 hours, sleep for 2 to 3 hours after feed, and gain weight adequately. Key messages for promoting exclusive breastfeeding: put the baby to feed at breast as soon as possible after birth, preferably in delivery room, and this is important for mother, baby, and milk production. On the first day, breast milk is thick and yellowish, known as colostrum, and feeding this milk provide nutrition and prevent infection, and do not discard this colostrum. Keep the baby close to the mother. It is safe for baby to sleep with mother, and mother may be lie down, sit or on the bed or a chair or floor to breastfeed her baby. Breastfeeding during day and at night at least 6 to 8 times, and whenever the baby cries with hunger. The more the baby suck at breast, more the milk the breast will produce and healthier the baby becomes. Give the baby only breast milk for first 6 months. Do not give goody, water, grape water, honey, animal or powder milk before 6 months, and never use bottle and pacifiers. Another important component, neonatal component, is a prevention of infection. There's a clean chain. The babies are securely placed in their mother womb. When they born, they have to be protected from adverse environmental surroundings. Cleanliness at delivery and the risk of infection to the mother and baby, especially neonatal sepsis and tetanus. Cleanliness required mother, families, and health professionals to avoid harmful traditional practice and prepare necessary material. Hand washing is a single most important step to emphasize to both family members and healthcare workers. The component of clean chain. Component of clean chain are clean delivery, WHO 6 clean, clean attendant hand, there's a wash with soap, and clean delivery surface. Clean string to tie cord, clean cloth to wrap the baby, clean cloth to wrap the mother, and after delivery, all caregiver should wash hand before handling the baby. Feed only the breast milk and keep the cord clean and dry, and do not apply anything on cord stump, and use the clean cloth as a diaper and napkin, and wash your hand after changing diaper and napkin, and keep the baby clothed and wrap with head covered to prevention of hypothermia. Last component, there is a recognition of high risk baby referral and management. High risk newborn defined as newborn with abnormal maternal, antenatal, peripartum, and neonatal indicators suggestive of higher than the normal risk of morbidity and mortality, who should be under control, under close observation by experienced pediatrician and nurse. Indicators: high risk newborn may be identified at birth, high risk pregnancy, high risk delivery, postnatal characteristic, there is an abnormal gestation, birth weight, there is a postterm, and congenital malformation. Early identification of high risk pregnancy during the antenatal visits, referral to suitable neonatal care center, if possible, intrauterine intervention. Comprehensive review of case record before delivery for resuscitation alert and adequate resuscitation facility and expertise at time of delivery. Assessment of delivered newborn for any high risk profile or warning signal and transfer to the appropriate neonatal care. There is a neonatal level 3 care centers. Thank you.
Thank you, doctor. We have a couple of questions. Can I
Right.
read it out?
Okay.
Yeah. The first question is oxygen therapy for newborns.
So usually 80% of the this baby do not require any neonatal resuscitation. Only the for a few times there is a oxygenation or stimulation or some this temperature control required. But in 10 to 15% case, it required oxygenation, because if you give oxygen more, there is also toxicity of oxygen also important to assess. If you give oxygen for a longer duration, it leads to retrolental fibroplasia, or there is a bronchopulmonary dysplasia in case of the preterm baby.
Thank you, doctor. The next question is neonatal testing for rare diseases.
Neonatal testing for rare disease.
Yes.
Which rare?
I think
there's a torch infection, toxoplasmosis, cytomegalo, herpes.
they have
Which rare?
mentioned is testing okay, or when we can go for neonatal testing where there are complications of any expected disease, rare disease or something like that. I think that's what I meant.
Which disease rare? We are
And
facing in this newborn, there is a torch infection, intrauterine infection. Also, normally there is a malaria or the HIV or any viral infection.
Okay. Okay, doctor. So moving to the next question, what are the common neonatal health problems that you have seen?
Normal neonatal problem. Most common problem is a neonatal hypothermia, because there is a large surface area of the body in comparison to body weight, and also the large surface area of the head, and there's heat loss is more. So there's a hypothermia. Second, the skin is also thin and vascular, so there's a heat loss and there's a hypothermia. Second important problem pertaining to neonates, there is a neonatal septicemia, neonatal infection, because there is a immunological memory is not fully developed in case of the newborn. And another problem, immediate, there is a neonatal hypoglycemia, due to there is a less reserve in case of the preterm or the low birth weight baby.
Okay, doctor. The next question is, how are the nutritional needs of babies in the NICU met?
If his baby is taking breastfeeding, so ideal frequency of breastfeeding at least 8 to 10 times. And when there was a child, there is a hunger cries there, give feeding. Second, Also give night feeding to prevent hypoglycemia. And third, if breastfeeding continue whenever there is a minor illness like diarrhea or common cold. So it prevents malnutrition if you give day and night and during the minor illness, and give exclusive breastfeeding. Also, it prevents infection like diarrhea and respiratory infection.
Thank you, doctor. The next question is, how do you monitor high-risk infant?
I already told there is a monitoring the fetal growth monitoring. There is a fetal heart sound, fetal movements. Also by certain, there's a fetal alpha protein. I already told everything how to fetal well-being monitoring and fetal growth monitoring.
Right, right. Doctor, there is one question, but I'm not sure whether we can answer this now. It's asking about the heart and blood. How are heart and blood circulation problems managed?
Which disease? Talking about which disease? Congenital heart disease?
Yes, cardiovascular disease.
So initially there is if there is a newborn associated with the congenital heart disease, there are the two types. One is cyanotic heart disease and second is acyanotic heart disease. And most common, there is acyanotic heart disease. If there is a preterm baby, there is a patent ducts arteriosus there, right? So normally it closes around in a first week, and if it is not closed in 72 hours, then there is a indomethacin in case of the patent ductus arteriosus for closing these ducts. And also if there is a cyanotic heart disease, there is a Fallot's tetralogy. If it is classical Fallot's, there is a failure is rare in case of the Fallot's. So there is a no treatment for these Fallot's cyanotic stage, there is a Fallot's tetralogy. But if it is cyanotic CH3, there is a transposition of great vessel. It presented with failure, then treat by these digoxin and Lasix.
Thank you, doctor. I think we have taken all the questions. Okay, there is one more question, doctor. What is Moro reflex?
Moro is a primitive neonatal reflex. It is a symmetrical Moro. It is in normal newborn, there is a symmetrical Moro. But when there is a fracture clavicle is there, then there is a asymmetrical Moro. If there is a kernicterus is there, when there is a bilirubin level more than 20 milligram percentage kernicterus, then asymmetrical Moro. If these primitive reflex, they persist for 3 to 4 months. If this persists more than 4 months, it suggests there is a brain damage and likely to develop cerebral palsy later on.
Okay, doctor. Yes, I think we have taken all the questions. Would you like to give some highlights that you have covered till now, important components where all the doctors should be aware of? Even a couple of nurses also have joined. So maybe some inputs for them as well as a message.
Right. Important component pertaining to the new essential newborn care, according to me, it is prevention of hypothermia. So immediately after the birth of the baby, there's a drying and covering. Second important problem is a hypoglycemia. So if there's a normal delivery, start this breastfeeding within half an hour, 1 hour after the delivery, and in cesarean section within 4 hours to prevent this hypoglycemia. Because it is, if you do not treat, then it leads to brain dysfunction and it leads to brain damage. And third important, there is a prevention of neonatal infections and neonatal septicemia. So that the hand wash is important thing to prevent neonatal septicemia. So according to me, 3 important components. One is neonatal hypoglycemia, second neonatal hypoglycemia, and third is neonatal septicemia.
Thank you, doctor. Dr. Sanjay, would you like to add any points?
Now, at the onset, let me just congratulate and thank Dr. Bharat Parmar sir for taking this very crucial and important topic and he explained so nicely the various components which are required for our neonatal resuscitation and essential for the newborn care. And 100% this is going to benefit all the viewers. And I must congratulate him for putting or for highlighting the kangaroo mother care, which is basically a very basic thing which can be followed in any kind of labor room or in any kind of neonatal NICU, or in fact in the ward also. So that really is very impressive, and it does really helps the baby also, and of course both the baby and the mother for the bonding and other thing. So I must thank Dr. Bharat Parmar for taking us to such a beautiful journey of the newborn care. Wish him all the best. Thank you so much, sir. Thanks, sir.
Thank you, sir.
Yeah. Thank you, doctor, for detailing
Over to
this
Sophia.
very important subject to us. And we wish you all the very success for your research and also upcoming projects. We would like to collaborate with all the future programs that you are planning to do, even under neonatal care, anemia, etc. Thank you so much, doctor.